So we now have a question from Dr. Rabe, Thana Rabe, and her question is, why did you choose that cirrhotic nodule in particular to focus on when there were multiple nodules?
When we're talking about the cirrhotic nodule, correct? I assume that is the case.
Yeah, are you able to go back to show that case again? Is that possible?
Absolutely, yeah. I used that one because that one was the largest and most apparent one. This was a patient with generalized iron overload. You can see that there are multiple cirrhotic nodules here. This is just the one that was most apparent as hypointense on the hepatobiliary phase, and it also had the most signal loss on the in-phase T1 weighted sequence. So that was my decision point there. Although there are, this patient is has many nodules in the liver, I'm just pointing one out.
Yes, okay. So Thana, did that answer your question? While we're waiting for her to respond, let me then go to Roberto Canella. And if I was Khaled right now, I would be saying buonasera or something along those lines, but I'm not going to try to be as funny or witty or charming as he is, so let me just get to his question. So his question is, or actually, Roberto, do you want to ask your question? Can you unmute yourself and ask your question?
Yes, can you hear me?
I can.
Thank you, very beautiful presentation. I appreciate a lot the discussion about the hepatobiliary phase. So my question is about the hepatobiliary phase hyperintensity. How should we use that? We know that it's not an ancillary feature, not strictly an ancillary feature, but a portion, about 10% of HCC may show hepatobiliary phase hyperintensity. And then there are also some regenerative nodules that are hyperintense on the hepatobiliary phase. So when we see those observations, how can we use this hepatobiliary phase hyperintensity?
So I personally don't use it as an imaging feature, and people might use it differently, but I personally don't use it as something to sway me one way or the other. If I see a nodule that is hyperintense in the hepatobiliary phase in a patient with cirrhosis who has that increased risk for HCC, I am not sure what to do with it. Now, this case I showed you was different because this case, there are other features that suggest that this is a high risk finding with the diffusion restriction and the sort of non-enhancing capsule appearance in the hepatobiliary phase. Those both suggest that this is more likely to be an HCC, but with the hyperintensity alone, I don't think that I would have that, use that solitary imaging feature to make me either dial up or dial down my level of suspicion.
Roberto, does that answer your question?
Yes, thank you. Just wondering why was not included as an ancillary feature in general?
Now hepatobiliary phase isointensity is an ancillary feature of benignity. I didn't show any examples of that, but I do find that helpful. And in my mind, the distinction between that is if something looks like hepatocytes if something looks like hepatocytes on all sequences or in most sequences and in the hepatobiliary phase, that suggests that it has a similar level of OATP expression, which suggests it is likely, it is more likely to be benign. So hepatobiliary phase isointensity is an ancillary feature of benignity, and I do find it extraordinarily useful when I see it.
Thank you. That's very clarifying.
Yeah. Now, So Roberto, to answer your, because some of these decisions, so by the way, Bill Masch is now a member of LIRADS, and as you can see from his lecture, he is extremely knowledgeable, and we're trying to figure out, you know, other ways that he can contribute to the continued development of LIRADS. But your particular question was a debate that happened in 2013 and 2014, and that was before Bill joined LIRADS, and so he may not know the answer historically. So historically, in 2013 and 2014, we were trying to figure out what to do with hepatobiliary phase hyperintensity. And we thought that because sometimes hepatobiliary phase hyperintensity is a feature of, say, a benign lesion, like a focal nodular hyperplasia, but sometimes it's a feature of an atypical HCC, we decided that hepatobiliary phase hyperintensity is neither an ancillary feature favoring benignity, nor is it an ancillary feature favoring malignancy. It's an imaging feature, and it's interesting, and it's useful. It tells us that it's of hepatocellular origin. You know, no self-respecting metastasis would look like the lesion, or no self-respecting cholangiocarcinoma would look like the lesion that Bill is showing us right now on this particular slide. But we didn't think it helped in terms of benignity versus malignancy, and so we decided not to call it an ancillary feature. Now, if I see, and I'm curious to see what Bill thinks, and I think Victoria's on the line, and I'm curious to see what she thinks. If I see a nodule in the liver that doesn't show any arterial phase hyperenhancement, and may or may not be visible in the portal venous phase, but in the hepatobiliary phase, I see it as a distinctive nodule that's bright in the hepatobiliary phase, and it's a small nodule. I think to myself, that's probably a benign nodule, and in my own mind, I'd call that a LIRADS 2. I probably wouldn't report it, so I may not even mention it in my radiology report, but in my own mind, I would think it's a LIRADS 2. In other words, and I'm just curious what, how Bill and Victoria would handle such a lesion. Maybe Bill, could you answer that first, and then we can ask Victoria what she would do with that?
I agree. I would handle it the same way. I would consider it LIRADS 2. I would, and if it was a solitary nodule, I might mention it in the body of the report. If there are many of them, maybe I wouldn't, but I probably would not make its way into the impression. That would be my pattern there.
And Victoria, I don't know if you're still on, but how would you handle that?
Well, according to LIRADS, well, first of all, we have to look at other ancillary and major features. You said major features were not there, but like make sure that no other ancillary features of malignancy are present. Assuming that is not there, then these nodules fall under LR2 distinctive nodule category because they have no ancillary or major features of malignancy. So I generally don't report those as well. Just either in the body report, if it's truly distinctive nodule, meaning I just see one of them, then I may describe it, but I don't put it into impression. If they're multiple, I won't even bother describing them.
Okay, thank you, Victoria. That was helpful. Is there anyone on the phone? Is there anyone on the webinar right now who would handle those in a different way? Please feel free to ask or to speak up. While we're waiting to see if anyone speaks up, Roberto, does that answer your question, or do you have any follow-up questions on that?
No, thank you. That's very helpful explanation, and yeah. I really appreciate that. I've now clarified this point.
Now, you mentioned, Bill, during your lecture that the lesions that are, the HCCs that are hyperintense in the hepatobiliary phase may be a little bit more indolent. Is that something that you find in the year 2020 to be clinically relevant? Does that change your management at University of Michigan? Would you, for example, not treat or treat more slowly or follow more slowly? Does it change anything that you would do if you thought it was an HCC with hepatobiliary phase hyperintensity?
Yeah, it would not. It would not change our management if we, in terms of what we would decide to do. If we had if we had a 20 millimeter nodule that we thought was an HCC, we would treat it the same regardless of what is hepatobiliary, whether or not it was hyperintense in the hepatobiliary phase. So say we had a Lyrad's 4 nodule, this would be considered Lyrad's 4. This is not 2 centimeters, but so this is a 12 millimeter nodule, and say we have this nodule, which is an LR4, and then we have a very similar nodule, but it is hypointense in the hepatobiliary phase, and it is also Lyrad's 4. We would not treat those differently. We would treat those similarly. So it would be a nice piece of knowledge, but I don't think it would change our treatment paradigm at all.
Okay, thank you, Bill. Let's see, there's a question from Daniela Parente. Daniela, would you mind asking your question, or would you prefer that I ask it?
Hi, good afternoon. Thanks for the excellent lecture. Can you hear me?
Yep, thank you.
So I don't know if I got it right, but you showed a hypointense nodule on hepatobiliary phase that didn't have hyperenhancement in the arterial phase. And usually I classify these nodules as Lyrad's 3, but you said something about Lyrad's 2, and I got a little confused.
So
not just one. I don't think it was.
Which it was this nodule here?
Yes, this one. Because I would if it is dark on hepatobiliary phase, I tend to classify it as a Lyrad 3.
Right.
Even if it's less than 2 centimeters.
Correct. So this would be, I think maybe what I said did not come across as clear, but this would be LR3. Because we have a distinctive nodule without major features, and we have an ancillary feature of malignancy, which is hepatobiliary phase hypointensity. And so if you have a distinctive nodule without major features and without ancillary features, that would be LR2 if it's less than 20 millimeters. However, if you have a distinctive nodule without major features, but it additionally has ancillary features of malignancy, and it's less than 20 millimeters, that would be LR3. So this would be LR3 based on the hepatobiliary phase hypointensity.
Okay, great. Thank you.
Yes, that was Daniela. Thank you so much for asking that question, and Bill, thank you so much for that very clear response. I think Juan has perhaps a similar question. Do you want to ask the question, or would you like to ask it? Would you like me to ask it on your behalf?
I can ask it. Thank you. Thanks for the excellent talk. We routinely use extracellular contrasts. So for your example of the 80 millimeter lesion, if assuming there's no other ancillary features, say diffusion was negative, without hepatobiliary contrast, and it did not show any arterial phase enhancement or washout, it will be LR2, and that patient will go back to surveillance, presumably. And would you then recommend hepatobiliary contrasts in most cases or not? Do you understand what I'm saying?
Right. So I think I understand what you're saying. So, you know, it could be very well that if you use an extracellular agent, the nodule seen here on this image would be not apparent. It might just look like normal liver parenchyma on the dynamic post-contrast sequences using an extracellular agent. So that is very true. This patient might be thrown back into screening. So this is a perceived advantage of hepatobiliary contrast because you can detect these high-risk nodules prior to them developing into progressed hypervascular HCC, and nodules such as this, which may be occult on all other sequences. So that is certainly a perceived advantage and a reason to use Eavist or Primavist, depending on where you're from. But I do also believe that it's it's a personal choice what you image with, because there are perceived advantages and disadvantages of both extracellular and hepatobiliary agents.
Okay, thank you. Thanks.
Yeah, that's a very interesting question, and it's a very interesting topic. I will say that in the year 2020, no one has yet proven that the detection of these hepatobiliary phase hypointense nodules, that their detection prolongs life. That's not to say it doesn't. It's very possible that detecting these nodules is clinically important and may actually prolong life, but no one has proven it. And the reason I'm mentioning that is that in order to change guidelines, we typically need evidence, and this is not a criticism, by the way, of Bill at all. I'm just saying that we an anecdotal case does not change guidelines, and it would be terrific if we as an international community could somehow figure out a way to do certain research studies like this. So, for example, does the detection of these nodules prolong life? Because if it does, then we could change the guidelines. Anyway, I thought it was a very interesting question that you asked, and Bill, I thought you gave an excellent answer, so thank you.
Thank you.
Well, I don't see any other questions. So if there are no other questions, are there other questions?
I have one question, please.
Oh, please. Yes.
Thanks. Thanks for such wonderful lecture.
Thank you.
If we go back to this case with LIRADS 4, with small henna lesions that went hyperintense in hepatobiliary phase, yes, this case, I see another lesion superiorly. I think it is in segment 4, which shows wash up in the portal phase. Yes, this one. This will it change your LIRADS if it is there?
So if this is a, I think your point. Can you see my mouse?
Yes, I can.
So is this the lesion you are talking about?
Yes. Yeah. Yes, it is.
So,
I think it shows washout, central washout in the portal phase.
Yes. So, again, like I showed this case to focus on the hyperintense lesion, not other lesions, and I am, I think that, to me, I am unsure if there's a washout or not. I do agree that there's probably hepatobiliary phase hyperintensity, but I would need to go up and down and convince myself of that. I'm personally of the mindset that I only
my question, if it is there, will you change your opinion about this lesion?
Would I change my opinion? Well, it wouldn't change my categorization of this nodule. I'm highly suspicious. Yeah. Right, I'm highly suspicious that it's an HCC, but it would be classified.
I think it will increase. It may increase your suspicion, not decrease it. I think this smaller nodule, I think it is nasty also.
Well, I mean, if there are other HCCs, I think that it wouldn't change my. I don't think it would change my suspicion. The way I look at this nodule. This nodule, I believe, is an LR4. I believe it's very likely to be an HCC. It was an HCC. that's ultimately what it turned out to be. But you can see that there's many things that suggest that is the case. There is a non-enhancing capsule, which to me is highly suggestive. There's also diffusion restriction, which is highly suggestive. So the presence or absence of another lesion, I don't think sways me one way or the other for this specific lesion. But I think I personally go lesion by.
I think the other one also is LIRADS 4, I think.
Yeah. Hey, Bill, do you mind if I say something?
No, go ahead.
I think this proves a few things. One is that we have an incredibly intelligent and astute audience. So here we have an audience member who is able to detect the second lesion, that wasn't, the lesion that you were focused on in your lecture. So I'm very impressed, number one. Number two, it's a very interesting question, which is, does the presence of a second lesion affect the categorization of the index lesion? And the answer in 2020 is that it does not change the LIRADS category. So if the lesion that Bill was talking about in his lecture, the LIRADS 4, if he were looking at that second lesion that you pointed out, and as he said, he'd want to go through all the images to convince himself that there is or isn't, washout appearance, and that there is or isn't hepatobiliary phase hypointensity. But let's say he did that and he became convinced that there really is a second lesion there and that it's a LIRADS 4. In the year 2020, that does not change the categorization of the first lesion. So both lesions are LIRADS 4. However, what it might do is it might change your diagnostic approach and the urgency with which you approach this case. So you might say something like, I see two LIRADS 4 lesions. They're both less than 2 centimeters. If they're both HCCs, then the patient can get transplantation exception points in the United States, because 2 HCCs less than 2 centimeters gives you transplant exception points. So you may do a more expedited workup, but you wouldn't change your LIRADS category. The third thing I'd say, and this is not in LIRADS, and this is speculation on my part, but if you look at those two lesions, they look different, right? One has both have hyperintense arterial phase, but one is taking up the gadozetate and the other one is not. One of them clearly does not have washout, the one with the arrow on it. The other one may have some washout, and the other one may have a little bit of a corona in the portal venous phase. So I don't think these two lesions are genetically the same. I don't think one is the metastasis from the other. I think this is multicentric hepatocarcinogenesis. I think these are two different HCCs that are growing independent of one another in a cirrhotic liver. Now, whether that's true or not, I don't know, and how that would affect your management, it probably would not affect your management, not in the year 2020. Anyway, very, very interesting question. Are there other questions from the audience? Well, if there are not, then I just want to say again, Bill, I really, really enjoyed your lecture. I actually learned quite a bit from you, and I really congratulate you. I'd also like to thank everybody for participating and for asking their great questions. I think Daniela sent me a question about research. Maybe I'll follow up with her later. And meanwhile, people keep sending me private text messages about what a great lecture you gave, Bill. So really, congratulations to you. So Bill, you have the last word. You want to say goodbye to everybody?
Yep. Thank you, everybody. Thanks for the opportunity and watching my lecture, and it was fun.
Okay.
And thank you, Khaled. All right.
Thank you.